I'm here. Thank you. And I see Val and Mike. Sorry to be running late, folks. This seemed to be the Zoom day to end all days.
And Sheila, we're still trying to clear the waiting room. If you can give it just a minute
Sure,
longer.
absolutely, absolutely.
And I believe I got Chad, Laura, and Shay all marked as co-hosts already, so they should be good to go when you're ready for them.
Okay, thank you. Let's see who else we have on from our voting members. Hi, Val. Hi, Mike. I know that Steve Shannon is out of the country. He had the nerve to take a real vacation. I think I see TJ there.
Yes, I'm here.
Great, thank you, TJ. So I know Diane cannot join us, so Eddie Reynolds would be the other one. And I don't see him yet, but we do have a quorum. We have 4 of the voting members on, so hopefully Eddie will join us as well. And I see a number of our DMS friends and a number of our MCO friends.
The waiting room is cleared.
Okay, thank you very much. And good afternoon to all. This is the point in your flight where the stewardess says if you're not going to Paris, then you're on the wrong flight. So I hope you're all on the behavioral health TAC flight, and we are welcoming all of you. We have our voting members, TJ Lidovic representing NAMI Kentucky, Valerie Mudd representing Participation Station and the Consumer Voice, and Mike Berry with People Advocating Recovery, which is our substance use disorder group. And as I mentioned, Steve Shannon is out of the country, and Diane had a work conflict, and hopefully Eddie Reynolds will join us. So I'll call the meeting to order, and I'll ask for a motion from one of our voting members to approve the minutes of our July 14th Behavioral Health TAC meeting.
This is Mike, so moved.
Thank you. And a second, please.
Second.
TJ, can you turn your camera on, please?
Oh, that's right.
Hang
Yeah.
on.
Yeah,
Thank you.
you're required to be in person kind of for open meeting, open records. So, all right. So we have a motion and a second. Any additions, corrections to the minutes? All those in favor of approving the minutes signify by saying aye.
Aye.
And aye. Thank you very much. Minutes are approved. If you all will remember, we had quite an active discussion at our July meeting about the provider credentialing. And Claire Arendt from Kentucky Hospital Association was very helpful in providing us with some information and then putting us in touch with the folks that are helping KHA and their partner, Verisys, I guess is how you say it, to do the provider credentialing. So I'm going to welcome Shay Likens and Laura Malloy. And Erin has enabled one or both of you to share your screen if you would like to do that to show your PowerPoint.
Hello, this is Shay. Laura is going to be sharing her screen, so give her just a second, please.
Sure. Thank you.
Yes,
Shay.
hi. Hold on, I'm pulling it up right now. Let me know when you can see it.
Yes, we can see it, and you're much quicker than
Okay.
I am. This is always the moment of truth for me. Where I have a backup. Somebody else can share their screen if I can't get mine up. So, and how do you say, is it Verisys?
It's Verisys. You were very
Verisys,
close.
like as in
Verisys.
verify. Okay.
Yes,
I'll remember that.
exactly.
Yeah. All right. Thank you so much for joining us. And I had sent you a number of questions that folks had. So we look forward to having your presentation, and then we'll see if there are some questions when you're finished, if that's all right.
That's perfect.
All right.
right.
Thank you.
Shay, I believe you're going to kick off.
Sure, I'll be glad to. Thank you all for inviting us to do a presentation today. We hope that we can answer any questions that you have. Of course, I am Shay Lockins with the Kentucky Hospital Association. I am the credentialing manager, and with me is Laura Malloy. She's the Vice President of Strategic Accounts and Implementation. And then also Amber Henderson is also a great contact at Verisys. Here's our information if you all would like to reach out to us afterwards with any additional questions.
And we will share the PowerPoint afterwards to everyone, as we always do. And thank you for making that available.
Sure. So KRS 205.532 allow KHA to form the Kentucky Health Alliance to perform credentialing services. For this venture, we contracted with Verisys, who was formerly Aperture Health, and they were well known to the industry to help with credentialing. In this alliance currently consists of Aetna Better Health of Kentucky, Passport Health Plan by Molina Healthcare, and WellCare. So some of the benefits of the Kentucky Health Alliance are to establish one standard application for the MCOs who are participating in our alliance, to reduce completion time of applications by monitoring the credentialing and enrollment dates to ensure that the KRS deadline is being met. So now there is timelines on when these applications actually have to be processed. To improve the communication between the MCOs, Verisys, the providers and facilities, to follow up on applications that are not submitted for re-credentialing or that are submitted incomplete. And then also to assist hospitals with employee provider credentialing to reduce the delay in the payment for the services that they've provided. And then I'm going to turn this over to Laura to go a little further into it.
Sure. And I included just a couple of slides about Verisys, just to give you a little bit of history. We've been in the business for over 25 years, really known as Aperture Health, Aperture Credentialing. I'm just going to kind of go through these slides pretty quickly. You can go back and view them, if you choose. We are NCQA accredited, URAC accredited, and we also have specific standards that we meet for committee functions. This just gives you a list of our different capabilities. And with this particular initiative, we're looking at our credentialing services that we offer. And these credentialing services fall in to these different categories. As Shay mentioned, we'll be assisting with application management. We'll be assisting with the primary source verification that goes along with the credentialing, as well as the committee services. So then to really get into the specifics of this Kentucky Health Alliance, we wanted to talk through how the process will work. And there's basically two different processes. One would be for the initial brand new providers who are coming into one of the plan's networks. And really nothing changes in step one. That provider is going to be reaching out to the respective health plan to begin that contracting and credentialing process at some point in time. When the health plan is ready, the plan submits the work order to Verisys. So the plan is really in control of when that credentialing request is going to get kicked off with us. Then we'll take that work order that the plan sends to us, and we'll start the primary source verification. When we start that, a letter is always sent out to the provider, or if the plan has a credentialing contact, it would go to that credentialing contact to directions on what to do with the application. In the case of a practitioner who uses CAQH. I'll show you the letter. It's going to direct the provider practitioner to CAQH. If it's a non-practitioner type, a facility, or different types of entities, there'll be a facility application attached to the letter. No primary source verification is started until we get the application back. So we're going to be in what we call app gather. We don't get an application, we'll be doing follow-ups out to the provider, reminding them that this is in process and we need the application. Those are in set intervals based on the plans have required. And then it's typically a 60-day app gather that's allowed for the application to be completed and submitted. So then in step 3, when we get the application, we'll then evaluate it. Do we have everything that's needed to complete PSV? If something is missing, then our verification coordinators will reach out to the provider on the email that's usually on the application and ask for that missing information. So, you know, it could be a variety of things. Maybe something expired. We needed some updates on information. That outreach will go to the provider. Once the primary source verification is complete, the information is then moved into the credentialing committee who evaluates it. The plan then will notify the provider. So notification of the results of credentialing comes from the plan. Does not come from Verisys, but each individual plan will send that notification and will handle any appeals. And then just through this whole process, once a provider is approved, then the provider will then move into a re-credentialing cycle with the health plan and will be added to what we call their monthly roster. Does that make sense? I think it's pretty straightforward. With re-credentialing, it's basically the same thing in that the plans drive when Verisys will start that work order for re-cred. What's different is that with these 3 plans, we're taking in their network rosters and we're comparing if a provider contracts with all 3 plans. We're comparing those compliance dates. So what's the earliest date that that provider might be due for re-credentialing? And we're going to take that earliest date. So, you know, if it's May for Aetna, but it might not be till November or December for Passport Health, we're still going to kick off that re-credentialing work order at the earliest date. So that would be May, and it will be on behalf of any of the plans that that provider is contracted with. So if the provider is contracted with all 3 plans, when we start that re-credentialing event, it's going to support all 3 of the participating plans. So the provider won't then have to complete something for Passport Health and then complete something for WellCare. We'll send a letter just like we do with initials. And on that letter, it will basically reflect the participating plans and give directions on where to go to submit the application or to return the application. Follows the same type of reminder intervals. We do target re-credentialing based on compliance state. So the schedule is really based on when that event needs to be approved in committee and back to the provider to know that they're approved for all the plans on an ongoing basis. So the difference between initial and re-cred is that the re-cred event is triggered off of the health plans, network rosters, and compliance date. And again, it's based on the earliest and supports all plans if the provider is contracted with all plans. To give you just a glimpse of what the letters will look like, you'll see the logos across the top of the page. So you'll know these are the 3 plans that are participating in the Kentucky Alliance. And then there is the verbiage. In this case, this is a practitioner letter. So it is giving directions about where to go to complete the application on CAQH. It's also giving additional information about if there's any questions, if a paper application needs to be completed. So maybe the provider isn't active on CAQH and doesn't plan to be, we will accept a paper application in that case. And there's a method to be able to upload that directly to a site. So you're not having to fax it or, excuse me, mail it. This is exactly what the letter is going to look like. And over here in the right-hand corner where it says client requesting information, that's where you'll see the plan names. So it could be one, could be two, could be all three. So that will indicate to the provider who all will be participating in this credentialing event. And so it will basically handle those 2 or 3 plans all at one time. Excuse me. The facility letter is a little different because with facilities we found sometimes there could be different services that need to be credentialed at the same location. They could have different MPIs. And so we get a little bit deeper into the detail of the letter with facilities and provide information as to the location that the plan has asked us to credential. So in this case, what's the MPI? What's the tax ID for that facility? What kind of facility is it? Is it a skilled nursing facility? Is it a community mental health center? So what type of facility is it? And then in this case, if there's a credentialing contact name, that would go there, or the primary service location name, whatever the plans have given to us. So in the body of the email, you'll find more detailed information about that specific facility. And we're doing that to try to eliminate questions, because a lot of times we will have some additional questions around specific locations. The facility application that will be attached to that Re-Cred letter will again have the logos, so you know this is supporting the Kentucky Health Alliance. And it is a 7-page application that includes this cover page. And I'm just really asking for the specific information around the primary source verification needs. The providers can expect to receive outreach if there is something missing from the application. So if you recall, once we get the application, that verification coordinator is going to look at it, see if it's complete. If something is missing, usually the outreach will come by email, and it'll be in this format. So I thought it would be helpful, if you're sharing this with providers, that they can see this is normal. This comes from Verisys, and it gives them the information that we're missing. Again, this is just kind of a test scenario, but it will say which plan it's representing. So if it's all 3, you'll see all 3, or 1. And then it also allows for the ability to upload information directly. So attach the document, upload it, or, you can always email back or call if you have questions. So that's kind of just a quick summary of the process in 15 minutes to try to just give you all an idea of how it's going to work. We are getting really close. We're hopeful that at the end of this month, we'll be able to kick it off. Shay and the MCOs, we're all looking at that and testing and reviewing now. So if it's not the end of this month, excuse me, if it's not the end of this month, it will be in October, just to kind of give you an idea of the timing. And Shay, is there anything else you would want to add?
No, the only thing, if for some reason your credentialing contact does not respond to any of the emails from Verisys, you will get a phone call and an email from me. And I will reach out several times to your office, to your personal cell phone, whatever contact information we have, to let you know what's going on and what's holding up your application, what the delay is. And then once we get that information, of course, we send it on to Verisys so that it can be reviewed and then sent on to the credentialing committee.
Thank you so much. In terms of the go live, how will you all notify folks that you're up and running? Or let me ask that a different way. If you would notify me when the system is up and running, I could certainly get it out to all of the organizations that typically are participants here at the BH TAC. And then through the Mental Health Coalition, we can also get it out to our network of folks. Does
Sheila,
that make sense for you all?
I'll be glad to let you know whenever our go live is set for. That way you can share that information as well. But we will have some communication going out too.
Great, great. Let me open it up at this point to folks that have joined us for this meeting. And I think many joined because they wanted to hear this and see if there are any questions out there. I can't see you all, so just speak up.
I do see in the chat that we had mentioned that it takes 60 days for the provider to complete the application. Once the provider's application is complete, how long will it take to be approved? So once we get 100% of the information and it goes on to credentialing committee, and those are usually hosted once a week. And then once the decision is made, it goes on over to the MCO so that they can work on enrollment or appeals or whatever that need is.
Yeah, and I see that, thank you for that. And thanks for the question, Dr. Terrio. I see that Kathy Adams from the Children's Alliance has a question also, Laura. How does a provider start the process? Will contacting one of those health plans, WellCare, Aetna, or Passport start the process?
If they're contracting, so if they're a brand new provider and they want to contract with one of those plans, it would be the same process as they would have done before Aperture or Verisys was involved. So typically I would think that's their first step. If any of the plans are on, they could also comment. Again, the plans will be the ones that trigger the credentialing event with us. So once they've completed that contract for initial, that initial provider, then they'll submit that work order to us. If it's a Re-Cred and they're already contracted with plans, they'll receive a letter that tells them that we're starting the re-credentialing process. And that will be their indication that, you know, we're looking for that application and for them to go to CAQH and update their information or complete the application.
Okay, if you're a brand new provider and you want to be credentialed with all three, what's the best process? Do you contact all three or do you contact one? And once you go through the process, it's easier than to be credentialed with the other two?
I think that they would all still need a contract with
Okay.
each respective MCO. So that initial provider would be reaching out to each respective MCO. Unless, Shay, there's another process that you all have created.
Nope, that's the process for now.
Okay, so in many ways, the process is the same, except that we've got an entity, Verisys, that is kind of riding herd on this, to my way of thinking, making sure that timelines are met, creating maybe a better communication back to the provider about what's missing, what happens next, and so forth.
And hopefully to eliminate paperwork and time on the provider's part, where if the provider is contracted with 3 plans, when it comes to re-credentialing, they should only have to complete it one time.
Okay.
Instead of 3.
Yeah, that makes a lot of sense. Any questions from anyone who's with us today?
Sheila, we are in negotiation with the other MCOs, so there may be others that are added to this as time goes on.
Yeah, that was another question that we had in July, I think. So thank you. I would hope that the other MCOs would see the wisdom of this and get on board. Anything that cuts down on paperwork for all of us, providers and payers, got to be helpful.
Exactly. And if you all have any suggestions, anything that you want me to look further into, please let me know and I'll be glad to look into it and see, if possibly there's a solution out there.
Okay, great.
Sheila, I had another question. I'm
Yeah,
sorry.
Kathy, sure.
So during the presentation, they spoke about the difference between a provider and a facility. And obviously a hospital's a facility. They mentioned a CMHC as a facility, which is something we normally, in my half of the world, we don't consider CMHCs facilities. But I was wondering what a BHSO or behavioral health MSG is. Are they a provider or are they considered a facility since a CMHC is considered a facility?
So this is Laura. I think that depends on how the plans are currently credentialing. So when I mention a facility, I'm thinking an entity, right? It could be like a home health agency, could be different types of non-practitioner entities that are contracted for Medicaid services. Something that wouldn't be a practitioner. If some of these organizations, the plans are currently contracting just the practitioners, I tend to think that they're also contracting with the entity, having a license and such. We would want to credential that entity. So it just depends on how it's structured. And I would look specifically to the MCOs or Shay that might have a better idea around that. I'm not an expert in that particular situation.
Yeah, because the BHSOs get licenses, the AODs, the alcohol and other drug entities get licenses.
Mm-hmm. Yeah, we would typically want to see that application. And it's called a facility application, but when you see the facility types, it is a variety of entities, non-practitioner types. And Shay, we could probably share that application with them. That might be helpful, which I only show the first 2 pages, but we can definitely get that application over so you can see what it looks like.
Okay, I think that would be helpful.
Okay.
Does that help, Kathy?
Yes. So it sounds like a BHSO or behavioral health multi-specialty group would be considered an entity, as they have various different practitioners practicing for them.
That would be correct.
Thank you. And so I guess one other clarification. So while it streamlines the re-credentialing process so that if you need to be re-credentialed with one of those 3 MCOs, it will take care of all 3 and it's just one application. For the initial application, you still have to submit individual applications to each of the 3 MCOs.
What's good about that's true. What is good about the application is the application was designed to support all 3 MCOs. So you complete it one time and it will support all 3. So you're not completing different paperwork, if you will.
Awesome. That's good to know. So it's one application, but it works for all 3 MCOs.
Yes, that's correct.
Okay, that's very helpful. I think the other question that came up, and this gets back to the kind of entities, facilities. So if you have an entity, let's say a CMHC, and you add staff who need to be credentialed, how does that work? You still need to submit the paperwork for each of those additional staff people?
For the providers, yes, you would.
Okay. But again, that process would be the same, whether that's a person who's in an entity or facility or has their solo practice with the application and the re-credentialing. All right, if there are no other questions, I'm so grateful to Shay and Laura for presenting this. And as I said, Erin will get this out to us and I'll make sure that you all get it and let's spread it widely, and we'll wait for an early go live. And thanks very much to Claire Arendt, who is the BH TAC representative from the Kentucky Hospital Association, for making this possible. So we appreciate it very much. Thank you all. And you certainly
Thank
are
you.
welcome to stay for the rest of the meeting if you would like to.
Thank you
Right.
for having
Thank
us.
you.
It's scintillating, let me tell you. So our next item on the agenda is a report on which providers are reporting patient no-show data. And that had been a Lee Geist question. She helped me formulate it better, and I sent it to Justin Derringer at DMS. And I don't know if he's on or not.
I don't see him, Sheila. I'm sorry. I can follow
Sheila,
up with him
yeah,
after
I'm
the
not
meeting.
seeing him either. I had spoke with Angie earlier. We'll see. I'll make sure that I reach back out to Justin as well.
Okay. He had said that he would try his best to get it ready for us, but he, is new in that position, I know, and I'm sure
Yes,
had a lot of pieces to pick up
sure.
and keep going. So
Knowledge, our history and our knowledge when we lose.
yes,
touch, right?
yes, right. Went with Lee. So if that's not available, we will keep that item on for
Sure.
the next meeting, and that'll be great. So we have now another presentation, and this is a follow-up on an earlier presentation that we had back in May on prescription digital therapeutics. And we're very pleased to have Dr. Katie Marks, who is the project director of CORE, K-O-R-E, the Kentucky Opioid Response. What's the E? I forgot. Effort. Yeah, effort. I'm sorry, Katie. So welcome, and we look forward to your presentation.
Got a message real quickly on my phone that said Queen Elizabeth has passed away.
Oh, how sad. Well, thank you, Val. I think most of us feel like we grew up with her as our queen mom or something. So yeah, thank you. So Katie, I will happily turn it over to you, and I'll let you take it away.
Well, I appreciate that, Dr. Schuster, and I'll also acknowledge the moment and maybe just respectfully take a second to pause for the loss of the Queen. And I know her role permeated our experience in American culture as well.
Certainly did.
All right. So thank you for the introduction. I'll make my portion of this brief, and that is to talk about what CORE's experience with Reset-O has been like, and to share with our pair partners in presenting some data. I think most of you that have ever seen me talk before know that I get most excited when I get to have data along with a conversation about clinical work. And so this is that perfect combination. If you're not familiar with CORE, though, CORE is a SAMHSA funded grant initiative that is awarded to the Department for Behavioral Health, Developmental, and Intellectual Disabilities. It has a very focused mission, which is to increase equitable access to high quality, evidence-based prevention, harm reduction, treatment, and recovery support services. And so we know that there's a couple key interventions within CORE that are really important to fund to reduce overdose death. And so naloxone distribution, or Narcan, is of course one of those. Medications for opioid use disorder, community outreach and engagement, care coordination, and recovery support services all fall under what we do. Contingency management, though, is extremely well evidence-based intervention that's been researched for decades, that shows that we can reduce illicit substance use and improve treatment retention by using monetary rewards to reinforce targeted behaviors. And targeted behaviors could be attending appointments, attending sessions, providing urine and drug screens that are negative for illicit substances. So contingency management from a theory perspective, NICS is really kind of simple. You provide reinforcers and people tend to adhere when those reinforcers are monetary or in some monetary form. But in practice, it's challenging to implement. There is a lot to do in terms of designing the contingency management program to fit the needs of the interventions being delivered. It can be challenging to track all of the behaviors, record them, provide payments to participants, track the payments. And so contingency management, even though it's really well evidence-based, has not seen the level of implementation that we need in the state. And so as we had thought about how CORE can support this EVP, the opportunity to partner with PAIR and their digital therapeutic that combines cognitive behavioral therapy techniques with contingency management just seemed particularly ideal. And so we sought to do a pilot with PAIR and with the Re-Credentialing digital therapeutic for two key reasons. The first was that SAMHSA has given us a challenge, and I say that in a somewhat of a joking manner. They have set a cap of $75 as an annual cap on the amount of reward someone can receive. And we know from the literature that $75 is just not sufficient. It's too low of a cap, but we have to pass that requirement on to our grantees. And so because the Re-Credentialing was designed to be able to provide a larger cap, we needed to pilot the test with a smaller cap. And so that was the first reason, was to pilot the $75 cap placed on individuals. And the other was to just have Kentucky specific, core specific data to look at uptake, both the provider perspective and the patient perspective on how this went. And we decided to partner with federally qualified health centers. They were great candidates for two reasons. First, several of them are participating in a project with the Kentucky Primary Care Association and CORE to implement medications for opioid use disorder in their clinics. And so they're already doing a lot of this good work towards supporting OUD treatments and stimulant use disorder treatments. And so this was a great addition. And the other thing is that many of our FQHCs don't have as much behavioral health infrastructure as they had hoped. And so the ability to provide this adjunct therapy that could be delivered in off hours that would not increase significantly provider burden seemed like a great fit. And so we came to PAIR, we said, will you do a pilot? We went to our FQHCs and said, would you participate in a pilot? And that's exactly what we've done. 100 people were included in the first round. We're doing our second round of funding at this point, but what we have to present to you today are the results of the first pilot, and I'll turn it over to our PAIR partners and to walk through the data, but I'm happy to answer questions at the end if that would also be helpful.
Thank you so much, Katie.
All right, thanks, Katie. I'm going to go ahead and see if I can't share my slide. Do I have that capability? There we go. All right, does everyone see my slides here?
Yes, thank you.
Great, so I'm gonna just quickly walk back a bit and just provide an overview on what we're talking about. I think we spoke about this a few months ago, but just to reiterate before we get into it, that Re-Cred and Re-Credentialing involve addiction-specific cognitive behavioral therapy that, alongside the contingency management reward system, provide a 12-week patient prescription that patients complete over the course of a, as I mentioned, a 12-week prescription. In combination with that, there is a provider-facing dashboard that we see in the second little screenshot here that providers, clinical care team members can access through a secure username and password, in some cases through an EHR delivery system, which provides the providers and the patients in some instances with real-time data on the patients as they move through it. The final little screenshot that we see on the far right represents the Patient Services Center, which is adherence support that's provided to patients who use the Re-Cred and Re-Credentialing therapeutic in regards to some of those patient fall-offs, patient drop-offs in treatment, as well as some technical or product-related issues that they might have as well. So Katie really well covered the collaboration with CORE and the objectives of the study. And so I'm going to walk right into some of the details, starting with just some of the demographics information in the trial. So here we just see over the course of the 5 months how patients were onboarded across these clinics into their practice, making a total of 100 patients in this first pilot. And then we see how they were distributed across different treatment locations. So we see by and far the majority of patients were treated at Whitesburg at the Mountain Collaborative Health Corporation. 72 of the patients were treated there, 14% in Cumberland, 7 in Harlan, 3 in Cornettsville, and 4 in Owensboro. We see the majority of patients were using the Re-Credentialing therapeutic. So that is the therapeutic that has indications for patients who are opioid use disorder patients specifically, and using buprenorphine alongside their treatment is the on-label indication here. The Re-Credentialing therapeutic on the right, which was a smaller percentage of patients, those are substance use disorder patients more broadly. Alcohol, cannabis, cocaine, stimulants would be the primary indications there. We'll start by looking at just who these patients were and how they reported themselves in terms of their age and their sex. These are data that we often see across different patient populations. Just for a little bit of background, I believe the total patient population that have been treated with Re-Credentialing in the state of Kentucky is over 1,000, but we see these same patterns in terms of the age and sex. So as we see here, most of the patients fell between these 30 and 49 age ranges, the vast majority of patients, but we had patients in 18 to 29 and some older patients, even over 60. We do tend to see a skew towards female patients. 61 to 37% of the population were female, which is actually pretty interesting, given that we do tend to see the prevalence rates and treatment seeking rates higher among males in terms of opioid use disorder specifically. But we do see that skew across our data for Re-Ced and Re-Ced-O. So moving on to some of the details around the study, the data we're going to be sharing are looking specifically at 79 of the patients who were considered engaged. So these are patients who started using the therapeutic and completed at least one lesson. So all of the data we're going to be walking through are looking at those 79 out of the 100 patients. Across those patients, they completed 2,351 lessons, or they engaged in 2,351 lessons and completed 1,638 modules. On average, patients who were engaged spent about 49 minutes per week inside these prescription digital therapeutics, receiving content, reporting cravings, reporting urges as they would. The final bullet point there just shows a little bit of that information that Katie also touched on. The patients do use this outside of hours where they might be able to see a provider. So we measure that as patients using the material, accessing sessions outside of what we might think of as a normal clinic hour. So we see 86% of the patients in this pilot used or started a session between 7 p.m. at night and 8 a.m. in the morning. And now we'll look into those data a little bit more specifically. This slide is just showing us patients' activity over the course of that 12-week prescription. So of course, 100% of the patients who were active used the therapeutic during the first week. And consistent with other data, we see fewer percentage of patients that are active over the course of the prescription. That can be for a variety of reasons. It can be patients having intermittent or inconsistent use over course. Sometimes patients finish the content early, but also, of course, patients drop out over time. But I think when we look at the fact that we have 60% of patients still engaged in weeks 9 through 12, in this patient population, I think these are pretty robust when we use comparisons related to things like buprenorphine adherence, which are in the 35% range nationally for patients at 4 weeks, or when we look at other data that we have around patients using digital health and wellness applications, we see those retention rates are about 1.5% after a month. So in that context, I know that these retention and adherence data are kind of difficult to process, but in that context, it can help us to understand kind of how robust they are. When it comes to lessons, this slide is looking at average lessons or average addiction-specific cognitive behavioral therapy lessons patients are completing on average over the course of the 12 weeks. So in the therapeutic, we consider perfect use to be 4 modules per week. We see the best outcomes when patients are completing 4 modules a week, but the core patients really did pretty well here. I would say received a passing grade. If we're considering 4 modules per week perfect, we see that even by the end of treatment, the patients that were completing modules were completing about 3.3 modules over that week. And when we look at that in a slightly different way, here we're looking at percentage of patients who did achieve that perfect use of the therapeutic. Here at the end of treatment, we're seeing 63% of patients in the pilot were completing those 4 or more modules over the course of a week. And we see some ebb and flow in that number over the course of the 12-week prescription as well. The data we see on this slide are looking more at those hours of day, right? So this is what we talked about before, looking at the patients using the therapeutic during clinic hours and using the therapeutic outside of clinic hours. So that's the figure that we see on the left. And so this is percentage of lessons completed. And on the x-axis, we see the time of day. So between 12 a.m. and 11 p.m. And we see the majority of activity occurs during those typical clinic hours. But again, we see a large percentage of patients use these therapeutics outside of those clinic hours as well. And on the right, we just see days of week. So we see patients use the therapeutic. For some reason, patients seem to use the therapeutic a little bit more on Thursday and on Wednesday and Friday than other days. But I don't know, there's a whole lot we can read into that either. And this is finally, the slide that we show here is looking at patients reporting cravings and triggers. So we didn't go into that very deeply, but patients have the ability to really in real time report on some of the urges, some of the cravings that they might be experiencing for a substance. And alongside that, they can report some of those physiological or psychological triggers that they might be experiencing as well, really provide some better understanding of some patient-specific issues where some specific content might be applicable. So this is just showing the numbers of check-ins, and we see how they did it over the course of day. And again, we see that same pattern where patients do a lot of it during the day, but we see patients reporting cravings and triggers even during the middle of the night and in the evening hours as well. And then on the right, we see the days per week of check-ins. So that's really what I have as a high level on the clinical data. I do think it is worth reiterating here that, as Katie mentioned, our therapeutics are typically provided with when we aren't subject to SAMHSA requirements around funding to a $599 price limit or contingency management limit. With the core grant, these were at a $75 contingency management limit, as Katie mentioned, in many cases is not sufficient to see the outcomes that we hopefully would from other trials using the larger amounts. Happy to take any questions.
Thank you very much. Let me see if anyone has any questions about the data, about the study. I noticed in the chat, Dr. James, that, oh, that's just to me. Can I share that? Tom, are you?
Yes, I came up. Yes, you can share that.
Okay, so Tom James, the medical director at Passport by Molina. Passport has a policy of covering FDA-approved digital prescription therapeutics. Most are in the behavioral health or diabetes area. Yeah, I think that would be interesting to see. And I guess my follow-up question with both with Dr. Marks and Dr. Shepherd is where are we with approval for these digital prescription therapeutics on the substance use disorder side?
Yeah, I'm happy to touch on that. These are both of these therapeutics, Re-Ced and Re-Ced-O, are FDA authorized as Class 2 medical devices through the software as medical device kind of pathway through the FDA, but they are authorized much in the same way through the same pathway as we see like a Dexcom or a glucose monitor has been approved under or has been authorized under. So it's a good question. Thank you.
So there was legislation in this last session, and I know Chad is on, can probably answer this because my memory's a little fuzzy. Was a resolution, I think, Chad, to urge
it was-
Medicaid to look at this issue.
Yeah, Dr. Schuster, it was a House Joint Resolution 28, and what it did is it requested that the Kentucky Department of Medicaid Services get a response back from CMS, whether they would cover it. And so right now, where we are kind of in that process is that by now, Kentucky Department of Medicaid Services should have sent that notice over to CMS. We've not heard back if CMS has responded yet or where we are in that process, but there is a report due by early December. That's going to go out to the legislature, goes to the administration, but it also goes to the federal legislators also. So we'll have a clear, concise idea of what CMS plans to do with this. Typical situation. Hopefully CMS doesn't take too long getting back to the Commonwealth, but that's kind of where we sit right now. So maybe an update from Medicaid would be great to hear if they've heard anything back, but we've not heard anything yet. So.
Leslie, do you know if Kentucky DMS has heard anything back from CMS?
Not that I'm aware of. If you don't mind, I'll follow up for you. Is that okay?
Yes, that would be fine. Yeah, I think we want to keep an eye on this, and Chad, if you're very good about staying in touch with me, so I'm sure I'll hear from you about what the status is. But if there is a report issued, I think there are a number of us that would be interested in seeing that when it's out. And let me ask Katie, and I should know the answer to this, but I don't. How much longer is the SAMHSA funding available for CORE and all the wonderful activities that you all are doing?
So the current SAMHSA grant ends in a year from now, and we're on our no cost extension beginning in 21 days. But the SOR3, which is the fourth award from SAMHSA, will begin September 30th. That will continue for 2 years through September of 2024.
Okay. So it looks good. Yeah, good question here in the chat. Are there any changes in the study design for the second cohort? I assume you mean for the digital therapeutics.
Not in the intervention itself. I know that there are additional FQHCs that are participating in this round, but the intervention, the CAP, those are all the same.
Okay. And then Marcy, Mental Health America of Kentucky is asking what data you have on employment status or work hours, whether there's usage during when people are not working.
I would say that we at Payer don't collect information related to patients' employment. Whether Katie's group collects that information, I'm not sure.
We collect employment, but the data is not linkable in that way. And so we wouldn't be able to answer that question.
Okay. It's an interesting question because I think there's been so much, and sometimes the legislators get real fixated on whether people are working or not, regardless of what their situation is. But I do think that we, when we think in terms of recovery, we want people to be able to return fully to their community and to society, and certainly work or school or those kinds of things are part of that. So interesting to look at that. Excellent presentation. We appreciate that. Any other questions from anyone on the meeting? All right. Well, thank you so much, and keep up the good work, Katie, with CORE. I'm sorry I couldn't remember the effort part. I should have remembered that first. It is great that we're having such a focused intervention around the opioid use, for sure. And we'll look for some follow-up information from Chad as things move forward. So thank you. Appreciate it.
Thanks, everyone.
Our next is a return to an issue that I keep hoping is going to get resolved, and then it does get resolved, and that's the claims payments for services to dual eligibles. So we heard in July that there still were some issues. Bart Baldwin could not be on the call today, but he did send a letter, which I'll read to you. For the MCOs that have bypass lists, providers are able to use them, but it's not without issues. The administrative burden is high for already overtaxed providers. MCOs have separate and distinct processes, which adds to the administration and time burden. MCOs still process claims in error and deny EOBs. It's a very time-consuming process, and ultimately it takes an inordinately long time for the provider to get paid, if at all. And it goes on to say that two of the MCOs, WellCare and United, do not have bypass lists, and so providers have not been paid for services provided and either accept that they will not be paid or have decided to stop accepting dual eligible clients altogether. And he asks for some assistance from Medicaid. Kathy, do you want to give a brief report of, I know you're in the data gathering stage with the Children's Alliance folks, but you're having trouble again getting the bypass list to work, I think.
Dr. Schuster, may I intervene
Yes.
for a second here? This is Stuart Owen from WellCare.
Yes.
We do have a bypass list. We've been working on it extensively and with providers. So we do actually have one. I think the complaint is that we don't publish it online, but we do have one. I believe we launched it in June. And you know, the big concern is we're required by law, Medicaid is to be the payer of last resort. And I know, you know, it's kind of a delicate balance, because some providers simply don't want to do anything to demonstrate that they've billed commercial first. So that's what the challenge is. But we've got a group that's been working on this very extensively, and we do indeed have a list. And I think it went live July 1. I know June 1. I know it was in June, but we do have a list. So I just wanted to share that.
Okay, so if a provider has someone who is a WellCare, or WellCare is their MCO, Stuart, how would they contact you to get the list?
You know, you might as well for now. That would be fine. That would be
Okay.
fine. I can get it. Yeah, and I can get it to the right people. That would be fine. I'll put my email in the chat.
Okay, that would be great.
Sure.
And that the list will, if we email you, Stuart, we will get the list, because I had some members tell me, just learned, I guess it was last week, that WellCare was in the process of developing a list, and then heard that it was developed, but that it wouldn't be, they weren't releasing it, and that literally you had to go code by code and ask your provider rep if this code is covered or not.
Yeah,
So-
I mean, well, sorry, I was going to say, yeah, I mean, because the concern with publishing it is that there can be, I mean, there'd be scenarios where the commercial insurer does cover it, but just the fact that it's published, providers will skip it. You know what I mean? They won't bill the commercial insurance first. They'll just say, here's the list. I'm not even going to bother with it. So that, you know, that's a concern. Again, and we can get audited by the Department of Medicaid Services. Why are you paying for this? You're paying as primary. Medicaid was not primary in this scenario. So like I say, you know, it's there's a balance there. You know, the provider still has the obligation to bill. So, but I know just from internal talks, we don't intend to publish it for that reason, because we don't want providers to just skip to, okay, I'm just going to bill WellCare for this, when in reality they're getting, you know, commercial insurance varies. The plan, they're different types of plans, not just different insurers. So it could be covered. And again, by law, you know, we're required to be the payer of last resort. So
I thought the purpose of the bypass code list was so that they didn't have to build the commercial insurance, because we already, what the MCO was saying with their bypass list is, we know commercial insurances won't cover these codes. Therefore, you can bypass sending your EOB to, or sending your claim to them and trying to get an EOB, which you rarely ever can get an EOB.
Yeah, I mean, I know that the group has worked at, they've identified given codes, you know, I guess higher volume codes that don't seem to be covered by commercial, and just kind of, you know, slowly building it out, I guess is the best way to say it.
Stuart, this is Paula, and we have had senior leadership is in the process of discussing a partial list of those, in fact, codes that are almost never paid by commercial. But again, I think the request from WellCare is that you file for primary in addition to filing with WellCare.
I thank you for that. I'd like to hear from the other MCOs that are on in terms of it. I understand what you're saying, Stuart, about Medicaid being the payer of last resort, but the issue has been that you can't get an EOB because they're not going to say that they don't cover that service, you know, and that's always been the hang up. So I guess I'm a little bit unsure why people have to go through that process if we already know that a commercial plan X is never going to cover codes, you know, ABC.
Sheila, this
Yeah.
is Dave with Passport, and
Yeah.
we have a list and we make it available. But I do want to say that I worked a couple of years ago very closely with the community mental health centers trying to get a list together. And there's a major problem in that different commercial insurance companies cover different services and they cover different codes. And you can identify a very small group of codes that never get covered. But to Stuart's point, when we're responsible for making sure that people try to bill the insurance, unless we see something or look at, you know, get some evidence that this particular insurance doesn't cover it, it is tricky to manage. I mean, I think, you know, we're trying to do it. We have a list and people can see that. And I know people are going to, you know, but you can't, you know, when we get this, you know, this provider bills for, you know, Bill Jones and they bill for Mary Smith, and they're still responsible if their commercial covers it to bill that first. And it is truly hard to manage.
And Dr. Schuster, I was going to say, there's the option for providers that we have to send an attestation, essentially, that we tried to build. We're not going to get the EOB, but we tried. We made an attempt just to document, you know, again, just to document, because we can get audited again. Why are you paying as primary? But we do give them that option. Just send us a statement that you attempted, or that it's not, that particular code is not covered by the particular plan. Again, there are multiple plans, but then, you know, it's not like one size fits all.
Right.
Commercial insurance. Yeah.
So is that the TPL form? Because DMS allows a TPL form, third-party liability, and it's basically a form saying that you can submit, I think it's after 90 days of you submitting the EOB to the commercial insurance, and you don't hear back, then you can submit that third-party liability letter and get paid.
Yeah, I don't know exactly. That makes sense. That sounds logical to me, but I don't honestly know. I can check on that. Basically, would the TPL form suffice as the attestation?
Yes,
Which-
that's the
okay.
question.
Yeah, I'll check on that.
So in that case, a provider who regularly deals with commercial insurance X and knows that they never pay for code, ABC, could sign an attestation form or this third-party liability form and say, they simply don't pay for this. So that's why I'm billing you, MCO.
Yes, exactly. Because there's got to be some kind of documentation. If we get audited, the state auditor's office, CMS audits, what proof do you have that there was no primary? There has to be evidence. So at least the attestation puts it on the provider, that they're attesting to that. And we say, here we go. We got this statement from the provider, something to document.
Okay. Leslie or somebody, Angie, I don't know. Can you send me that TPL form so we have it, please?
Sure. Angie. Yes, our program integrity division.
Okay.
Yeah,
All right.
Sheila, I'm sorry, I'm frustrated. I feel like we're chasing our tails because years ago, 2-3 years ago, some of the MCOs were accepting the TPL forms and life was a little bit better. And then the MCOs stopped accepting the TPL forms. And so now it seems like we're circling back around again and saying, oh, we'll accept the TPL forms. Until they program their billing systems to accept that TPL form, it's going to kick the claim back. And we're back to where we started and go back to Bart's letter of it is just so time consuming to jump through all of these hoops to try to get paid for something like targeted case management, comprehensive community services. Those are services, show me a commercial insurance that provides and will cover those services. It was my understanding that the purpose of the bypass list was to, is that the MCO had acknowledged that commercial insurances don't accept these codes. Therefore, the provider can bypass sending these claims for these codes to the commercial insurance and bill them directly to the MCO. I thought that's what a bypass code list was, but apparently they're still expected to send bills to the commercial insurance even when there's a bypass list. I mean, this is the first I've heard that. And then the other thing is, providers can't do all of this. I understand, and we have been told that the very reason DMS doesn't have a commercial bypass list is because there's so many commercial insurances out there, and you have to ensure that Medicaid is the payer of last resort. So again, do we have bypass lists and can we use them, or is the expectation still that we send it to the primary insurance? And then the other question that Bart raised was that now the bypass code lists aren't working anymore. For some of the MCOs, the bypass lists aren't working. And I've reached out to our members to try to assimilate some examples of that. But we had a meeting with our billing staff last week, and Bart had raised that issue with me. I hadn't heard it. And then when we met with our billing staff last week, definitely it came up. And, unfortunately, the bottom line is, as you have said numerous times, Sheila, here is somebody that has commercial insurance and Medicaid, and they should be getting better services. And what happens is they don't get any because the Medicaid providers can't continue to provide services and jump through all these hoops to still never get paid.
Kathy, a quick point. If I misspoke, if I said, if it's on the bypass list, then you don't have to submit proof. If I said that you do, then I misspoke.
Thank you.
Sure.
That's what I understood. That's what I heard. So I may have heard wrong.
Okay, yeah. That helps, Stuart, because I had understood you to say something different than that.
Sorry about that.
Yeah, when I think back, and Steve's not here, but Steve and I have wrestled with this for 20 years, I know. And it just makes no logical sense to me that people that have two coverages are more likely to not get served. And my real concern, and we know it's a lot of times it's kids that have the commercial plan plus Medicaid. And I really worry that our providers are going to quit serving them. I mean, if you think you're not going to get paid, or the cost of getting paid is more than what you're going to get paid.
And that's exactly what's happening.
Yeah, I mean, one of the good things about behavioral health providers is that they continue to provide needed services, whether they think they're going to get paid or not. The bad news is that they keep providing services, whether they think they're going to get paid or not. And we're coming to a point, I think, where the margins are so thin, and there's so much work to be done and fewer staff to do it and more people in need, that quite frankly, I could see an agency or a provider saying, hey, if I have a choice of serving Johnny, who has commercial plan X and Medicaid, or Susie, who has just Medicaid, it would certainly push you in the direction of serving Susie, quite frankly. And that really is of concern. Let me throw in something else, because I had not read my own notes from the meeting. And so belatedly, I reached out to Angie Parker, and she had mentioned Jeremy Armstrong, who's the branch manager. I guess it's Jeremy Armstrong, the Rossett. And I got a very nice email from him on Friday, actually, saying, I am very willing to work with you all and with the MCOs. And so I have reached out. Bart knows that, Kathy knows that, Steve Shannon and the CMHCs know that. If others of you are having these dual eligible issues, if you want to send the information to me, I'll make sure that Jeremy gets it. Or Angie, maybe you can put his email address in the chat. That might be a more direct route.
Yes, ma'am, I'll do that.
Yeah, thank you. Let's do it that way, because I don't want to be responsible, and I'm not sure I need to know all the details. But he said, make it as detailed as possible so he knows what the situation is. So name the MCO for sure, name the commercial insurer that's involved, and what your road to not getting paid has been. And so he has offered to be in that position, and we will keep this on the agenda. This is one of those, I think, Kathy, that we may never get rid of. Hopefully it'll get better. But let's get some clarification as well. Maybe, Angie, I don't know if it should come from you or from Jeremy about the use of the TPL, and how that would help or not help.
I was just talking with Jennifer Dudinsky, who is our division director in program integrity.
Yes, thank you, Jennifer. I see that you're on and helping out here.
TPL and the TPL list, but we can certainly, I know that this TPL form has been shared with the MCOs before. And we can certainly look to see who is using it or who is not. But I guess if you are not getting that information back from the MCOs, they may not be using it now, but we'll look into that.
Yeah, I think if you all at DMS, Angie, could put your heads together and just give us some guidance about whether the TPL is something that ought to be submitted with the claim to the MCO, if that is helpful. I'm still a little confused about what all needs to happen. in this. And if you need to talk with a couple of people, let me know and we can set up maybe a Zoom with some of the folks that are involved.
The DMS has the TPL form and the instructions as part of the BHSO and Behavioral Health MSG billing manuals. So that information is in both of those manuals.
Okay. I have not heard about it on the CMHC side, but that's usually Steve's bailiwick. So I'll have to see. I know we've got some CMHC folks on here, but whether they're the billing people or not, I did reach out to the CMHCs that I know Bart did as well. But let's see if we can get some clarification on that. Bottom line, and I think we all have the same goal here, providers want to be able to serve everyone who has Medicaid, whether they have another coverage or not, number one. Number two, the people need the services. And number three, the providers need to get paid for providing the service. And there's Jeremy's email address. I also just sent it to him at jeremy.armstrong@ky.gov and he got it. Angie.
Okay.
Yeah, that's very helpful. Thank you very much.
Mm-hmm.
We also, and again, this is something the MCO audits we thought were kind of solved, but we're hearing again that they're up in number and up in duration. And I can't remember, Kathy, did you have anything specific on the MCO audits?
Just that it seemed like I wasn't hearing as much, as many complaints, and they've started up again. We had an example given by one of our members, and it's a huge member, that in 20 to 21, they had 250 to 300 audits, pre-billing audits, prepayment audits. And in this last year, they've had 2,800.
Wow. Whew. That kind of takes your breath away. Angie, I think that you've told us in the past that people, there's some limitations. Certainly, they're supposed to give 30 days at least for a reply, and people could ask for more time and so forth. But if that number is an accurate number, just the sheer number of things to be dealt with seems extremely difficult. Are you all at DMS putting any pressure or requirements on the MCOs with regard to audits?
Sheila, this is Leslie. The only thing I can think of right off the bat is because there's still no prior authorizations for the most part. So there is a back end check. There's nothing that we've asked for more audits or anything like that. I'm just saying there is no prior authorization. So of course the MCOs are still held accountable for quality assurance and best practice and things like that in billing.
Yeah.
It was my understanding though previously that they can ask for more time unless an MCO disagrees with me today. I think it was offered for additional time for submission.
Yeah. So you're going to put the time in and it's either going to be in justifying it on the prior authorization end or you're going to get it on the audit end is essentially the situation.
In some circumstances, that could be the reason, yes. But as we have mentioned before, if the provider's having challenges with meeting that time frame, that the MCOs can certainly ask for additional time, and the MCOs should be able to grant that.
Yeah. So the only relief actually is there's no relief on the numbers, the sheer numbers of audits. It's really on the time frame for replying.
And Jennifer Dudinsky, who is also on program integrity, I don't know if you can discuss any of the audits in place, if this was, it would be appropriate. But as far as the sheer number per provider, that is based on the claims that they're receiving. And as Deputy Commissioner Hoffman stated, they do have the ability and they should be auditing certain claims to determine medical necessity.
Okay. So basically what they're saying is that since we don't have the ability to determine if the service meets medical necessity, we're going to come back at the after the service has been provided to ask for that justification.
They can do that, yes.
Okay.
And Jennifer's going to respond via text. She is having a little bit of issues with her voice today.
Yeah, I see that. Thank you, Jennifer. And we'll come back to that.
Angie, is there something, it's just, I'm sorry, it's left my train of thought. That didn't take long, did it? I'm sure it'll come back to me. Sorry.
Jennifer responded. It says, I think the audits that you're mostly referring to are likely to be TCM audits, and those are required of us. Therefore, we can only be lenient in regard to the timeframes.
So those are targeted case management audits. And
Sheila, I can speak just a tad to that. We've had 2 state audits and 2 federal audits and another one that's came back around again. So we're held very tightly to the gun to provide that information. And that was an audit that came to program integrity as well as the behavioral health group side. So I wasn't thinking about that, but that definitely could be a driver.
So is that from the feds?
It started out as a state audit, then it went to that drove to a federal audit. And this is when I first returned back. Then since then we've had another state audit that was driven to another federal audit. And I think we just had one more state one recently. So it's probably starting to very much compile on each other after this many audits. And we usually provide those responses jointly between me and Angela in her previous role, and then Jennifer Dudinsky's group as well.
Okay, so you all, I know that you've said in the past, Leslie, and I understand. I'm not, I'm trying not to point fingers, or we're just trying to get services done and keep providers in business and make sure our Medicaid folks get what they need. So I know that you all have a responsibility, and you have to report to CMS that you're auditing what's being done in Kentucky on all Medicaid services, right?
Yes, and we have a state auditor as well. So we have a state auditor, just like anybody else. We have a state audit that checks us, and then we have a federal audit if the state auditor has additional questions that we weren't able to answer at the time.
So, and those state audits have been specifically around targeted case management?
Yes, ma'am.
Okay.
And that started right before I returned a couple of years ago. So like I said, we've been through several rounds now with those audits, both state and federal.
Okay. So at least, I guess the answer, Kathy, then it would be interesting to go back to your person who had 2,800 audits to see how many of them were about targeted case management. Just out of curiosity.
I could do that. They didn't clarify at the time.
Yeah.
I hadn't thought about that, and I apologize for not thinking about that.
No,
So
that's all right.
that could definitely be a driver for you, Sheila.
Yeah. Well, it also reminds me that we still have, some data and some follow-up steps with Commissioner Lee on that targeted case management data. So I'm hoping that we can use that in some ways to respond to some of these issues.
Sure. Is there anything you need me to do on that follow-up? Are you waiting for her? I know we finished the data.
I was waiting for her. She was going to get in touch with the UK.
Oh, that's right. I'm sorry. University partnership for.
partnership with all the data collection over there. I forget
I
what
remember
it's
her
called.
saying that.
And
Okay.
I have never heard from them, and she thought maybe they would be in touch with me. No, not Kiprick. No, not K-SPAN. It's the data analytics, isn't it?
OHDA.
That's no, it's the UK.
IPOP. I get right.
University partnerships.
Ask the commissioner.
Okay, so I'll check on that one for you.
I know the guy's name, and I
Jeff Talbert's group.
Jeff Talbert.
Yeah.
Yes.
He used to be with IPOP. Now he's moved.
All right. So whoever he's with, he's the guy. And he's the last that I talked with the commissioner about our data. She said, I want to pursue this more and let's get UK involved. And I'm going to talk with them and they will be in touch with you. And I have not.
Yeah. Okay. I'll follow.
I think it's Talbert, not Talbot.
Yeah. Sorry.
Yeah.
Kathy, Jennifer said if there's others outside of the target case management, she's happy to look into that and figure out what's going on.
Mm-hmm.
Oh, okay. That would be helpful. So one of the things that I'll get back with Bart and talk to Steve as well is we're gathering information to get to Jeremy. Let's look at what these, no, that's dual eligibles. Pardon me. Forget that. Yeah, let's look at what these are about. That would be helpful. Thank you.
And I did remember my question. I'm sorry.
Yes.
And that is that some members indicated that they're being audited back to 2019. And I know that there's either KRS or KAR that says that audits can go back 24 months, I think, from the time that they were remitted. And then some seem to think that DMS put something in writing that allowed the MCOs to audit back to the time when PAs were waived. So is there anyone that can provide clarification on that?
Angie, do you
Jennifer
remember?
Says in the text that some audits could go back 5 years.
And do we know which ones those are?
Yeah, maybe Jennifer or Angie, somebody over in the program integrity can do a little research for us on that.
Thank you.
She says the TCM audits are likely going back to 2019. So that's when, but in 2019, prior auth was in place. Okay, she's going to get us information on the audit timeframes, Kathy.
Great, thank you.
Thank you very much, Jennifer. So we will keep this again on our November agenda. Leslie, any update on our waiver for incarcerated people?
Yeah, I think if it's okay, Sheila, I'm going to go back. I put some information there in the chat. Let's start out by just talking about there's lots of moving parts right now. You know that.
Yeah.
So our big Kentucky 1115 authority that allows us for all those wonderful flexibilities and allows us to do things outside the, thinking outside the box kind of things. It's time for renewal. So we have it out for public comment right now. And I just put in the chat the link. The public comment is still open. If anybody on this call is interested in sending in the public comment, I think it's until the 13th. We have already completed, and I think some of you attended our 2 forums that we had, and it was publicized in at least 3 of the largest papers. You can send public comments to the commissioner's office, and all of that is in that link that I just sent you. Just make sure that we have contact information, contact agency if applicable, and contact information including your address as well. And then we will get responses posted back out within a week or 2, and they will be posted on the DMS website under the comment section prior to submission of the application. So we have to do all that prior to sending it to CMS. So within that 1115 authority, we are asking not for a lot of changes, but I did want to let you know that we've asked to rename it Team Kentucky 1115 and get the old name completely out of there. It brings up a lot of issues for folks, so we want to get that name out. Also within the 1115 demonstration, it includes the incarceration, and they know that we're going to continue work on that, as well as, if you remember, the SUD officially is only in year 3 of 5 years, but they've asked us to renew that as well so that we can get our timelines together. So we've submitted that we've got that out for public comment till the 13th, and then we'll proceed there. Because this is an 1115 for all of Kentucky, and it does have pieces that have nothing to do with behavioral health in it. Other pieces that CMS handles, employee assisted insurance and or sponsored insurance and former foster care and things like that. So we have other pieces within that big period or big 1115 extension. The extension is actually due 1 year prior to the end. So that means it's due to CMS around 9/30. It will require a approval and letter by the governor. So I wanted to let you know that. So that's kind of where we are. There is a hope that they can go ahead and approve the amendment since it was submitted prior to the submission of the 1115. We are still working with CMS on an ongoing basis to work on the incarceration amendment. I feel like a broken record every time I'm on here. There is nothing negative related to the incarceration amendment. They are literally just trying to get their own policy and procedures in place before releasing us, being the first state that's tried something like this. I think they're up to over 20 now. It was 19. I think they're around 22 requests from other states now. So they want to get it right with us when they roll it out. So we're very excited about it still and hoping to have you some information fairly soon. Again, I can't tell you any timeframes because it'll be left up to CMS on their approvals of the big authority to also include other authorities that are within that. Our SMI SED waiver, Sheila, that we're drafting, as well as other components that we're working on for SMI, those things will come along after the approval. So they can be there pending, but they won't approve it until we have the big authority on the 1115 side approved. So I told you a whole lot. I'm sorry.
Yeah, so that's the approval of the extension.
Yeah, it's the
Has to
great
take
big, it's our
precedence,
big
yeah.
authority for all of Kentucky. So all of our behavioral health stuff just falls under that in bits and pieces, as well as some other Medicaid functions, but the rest of it was repealed, of course.
Yeah, okay. Thank you very much.
Yes, ma'am.
For those of you who are not speaking directly, if you could mute your line, I think there's some background conversations going on. Thank you very much. I wanted to ask those in attendance if there are any issues right now with the Medicaid formulary or with access to medications. I've not heard anything recently. And again, we keep this on here because medications are so very important to our folks, but I have not heard anything. Wanted to give you all a chance to ask any questions about that or pose any problems. So hearing none, that's great. Number 10, this is a huge victory for us. If you remember in July, we made a recommendation to the MAC that DMS do frequently asked questions about their new guidance. And they did us one better. They not only said, yes, we'll do that, they actually produced it. And then they also produced a very attractive flyer. So Erin, if you could share your screen and just show the FAQs. I think I sent them out to everyone I had on my email list. Which reminds me, if you want to receive notifications of the BH TAC and any materials, please email me directly and I will put you on that list. It's an easy email to remember. It's kyadvocacy@gmail.com. Marcy, maybe you could put it in the chat for people. I would appreciate it. because I have a pretty large list of people that I send to, but we're happy to send that out. Thank you, Marcy. And Aaron, can you post the frequently asked questions document?
Is it not showing? One
No,
second. I
no,
pulled it
the
up. Let me-
agenda is still up.
I was hoping if I just switched,
Oh, nothing's easy. You know how that goes.
I should know better.
So this is quite a lengthy document. It goes actually 3 pages or 2.5 pages. It's very detailed, just exactly what we wanted. And it talks about the previous bills. It talks about what the regulation does and does not do. It goes into asynchronous versus synchronous telehealth. Also points out, and this is important for all of our licensed providers on here, that your licensure board may have its own regulations about how telehealth can be used and who under their purview can use it. I know some of the licensure boards do not let some levels of licensure do telehealth, which has never made any sense to me, but that's up to each licensure board. Talks about Medicaid and the billing codes, and they're not looking to create any billing codes. CMS, the federal law, requires that you be in the United States. If you remember, House Bill 188 passed this last session. You may want to look at that because it directs the licensure boards to allow providers who are out of the state to provide telehealth back to their in-state clients and vice versa, that you could be in the state and provide to a client who's out of the state. Unfortunately, when House Bill 140 passed in 2021, over in the Senate, they made a change and the MCOs can pay a differential amount, usually a lesser amount for telehealth than for in-person. That was never the intent, I don't think, of the original telehealth legislation. And I think that's unfortunate because people are getting basically the same service. But it also talks about the asynchronous versus synchronous. One of the concerns about asynchronous is that people are not getting direct contact with the licensed provider. They're handling something through a staff person and then it's being reviewed later, which I think is very different than having the interactive session with the provider. So I'm extremely pleased that DMS responded so well, and we had a great session. And then they did this really nice one-pager with graphics and kind of, very succinctly talks about telehealth. So this is well worth, I think, distributing to your members. I'm thinking about the CMHCs, Kathy, your children's alliance groups and so forth, to just be real clear about what the regs do and do not do. So our thanks to DMS for taking our recommendation and doing such a beautiful job and doing it so quickly. So Leslie, Angie, those of you on from DMS, please thank the responsible folks, because that's I think a huge benefit for everyone. Actually, not just in behavioral health. Remember, this is not just behavioral health, telehealth, it's also physical health. Any questions about that? Okay, thank you very much. I don't believe that there's been any recent update on prior authorization guidance. Am I correct about that, Leslie?
That's correct. I double checked with Jonathan today and he may be on. So I believe they would have had to notify us by November. Again, I'm saying I believe, right? Because I don't have anything specific, but they would have had to let us know like in November for the 60 days. They've promised that they will give us a 60-day notification. Jonathan and I are still hearing, though, that it's going to continue on at least till the end of the year. Now, that's not a promise. I'm just saying what we're hearing.
Yeah, you're talking about
Federal
the
world, yes.
the federal public emergency period, right?
Yes, that's correct.
Yeah.
And
Okay.
currently all we have is just the 2 prior authorizations for behavioral health that we have turned on that you're aware of.
Yeah.
Residential and inpatient.
Yeah, the last rumor I heard on the federal public emergency was that it would go through the end of the year.
That's what we're hearing too.
Yeah, that would be great. All right. The interim session meetings continue to go along. There's not anything that's specific to behavioral health. There's been a number of presentations on workforce shortages. And while there hasn't been anything directly on behavioral health, I think we all are very aware that we have got to really put our heads together and recruit more people to come into the behavioral health field. I don't know of anybody who's doing any outreach at the high school level, but it really needs to start there. I'm hoping with the influx of behavioral health providers in the schools that maybe more of the students will, kind of light a bell with them that this is a good profession to be in, whether it's social work or psychology or psychiatry, psychiatric nursing, counseling, and those kinds of things. We also need to be recruiting more behavioral health providers from our communities of color. There's always been tremendous stigma, unfortunately, in the Black and brown communities around seeking help. And I think with COVID, we're seeing more people reaching out. And I think therapy and interventions have got to be more effective if you are sitting in a room and looking across at a therapist or a counselor who looks like you and may have some of the same background and shared experiences. So just something to be thinking about. In November, most of the task forces that are there, and one of them is on the emergency or EMS responses. So we'll be watching that specifically to see if there are any recommendations that come up around either 202A transportation. I know it continues to be a problem in the eastern part of the state. And now, of course, with the floods, I'm sure it's, magnified there as well. But usually the task forces come with their recommendations in November. So we'll be looking for those. Do any of the voting members of the TAC have any recommendations that you think we ought to put forward to the MAC at their September meeting? I did not have any, and I didn't get any from anyone beforehand. So seeing none, we will probably just make our report of the meeting. We have lots of agenda items for our next meeting because we have a lot of carryover items, the no-show portal, the dual eligibles, I just lost my train of thought because someone's knocking at my door. Marcy, you want to go on to new business? And bring up your issue, and I will be right.
Okay. My question for Medicaid is, do you cover psychiatric hospitalizations of children with autism or other severe behavioral health issues?
Do we cover hospitalization?
Yeah, psychiatric hospitalization of those under age 12.
Let me get additional information from you. I don't want to just speak off the cuff. If any of the MCOs want to chime into what you cover, but I don't want to say anything specific to autism until I research that, if you don't mind.
This Stuart Owen with WellCare. I would just note that it depends on the criteria, interqual or minimum, whichever is used. It's not, do they meet the criteria? It's not like this diagnosis or not, it's just, do they meet the criteria for admission? And I'm not aware of any kind of limit regarding that.
Just for passport, I mean, there is an issue. They have to meet hospitalization criteria, but I know that we have kids under 12 with an autism diagnosis who are in the hospital or have recently been in the hospital. And we're paying for their care, just to be clear about that.
Thanks.
Thanks, David. I didn't want to speak off the cuff. I know as far as autism goes, I know I didn't want to speak any specific diagnosis. I know we did have children that are out there right now.
Yeah, we're having a real lack of providers accepting patients who have both of those issues. I've had several families reach out to me having trouble when a patient really does meet criteria, but finding a bed for them, finding a willing provider as well. So just wanted to kind of put that back on. I know it's an ongoing problem, but
yes, and we know that we've got several committees that have started meeting around especially hard to place children and things like that, and we're trying to take a look at some of those issues on the SED side of our SMI SED waiver, and what can we change in state plan, what could we do as a pilot, what could we do quickly rather than making an amendment to the 1115 that'll take a longer period of time. So yes, we're aware. And Marcy, if you want to reach out to me, I can help on the side as well too with specific cases. Dr. Lohr, I don't know if you're familiar with him. He works in public health, but he also helps us in Medicaid too also. So we can see if we can work on some specific cases.
Yeah, I could put you in touch with Dr. Lohr, also Marcy. I think there's a group that meets out of Louisville at 7 in the morning. That's a pediatric mental health group. And one of the populations of kids that we've talked about are kids who are both developmentally, intellectually disabled and have significant behavioral health issues. And of course, that's a population of adults that we also have trouble with. And I see where Michael Gosser has also reached out to you from Peace. I think that there was a statewide meeting last year with legislators and Dr. Brenzel and Commissioner Morris were on, and the question came up about transporting a child who needed hospitalization. And, the comments were kind of, we don't have a state facility like we do at Eastern State, Western State, Central State, and so forth. To provide that. So Dr. Brenzel's on. Do you want to comment, Alan?
Sorry, trying to get back on here. Not specifically in terms of an answer. Certainly acutely aware. I put in the chat that I met today with the Norton's group from the Autism Center, as well as the specialty clinic, as well as their Norton adult outpatient, and the issue there was to access to services and the limited numbers of sort of coordinated care settings. But we've recognized that, and we have a number of folks right now in our state psych hospitals as adults that are there based on SCL providers having experienced a lot of duress at this point in terms of staffing inadequacies and inability to stay fully operational due to staffing shortages. So then with a lack of inpatient beds for both kids and adults for the comorbid population, we're actively exploring the possibility very, very early of, some sort of dedicated unit at the adult level for folks with intellectual disabilities. And then there's some conversations with the hospital association about that population as well. So it's recognized, but I don't see an easy solution on the horizon. Some of that is capacity issues that I think some of the capacity is starting to come back online, but child and adolescent beds are at a premium still.
Yes, absolutely. And that's helpful. It also occurs to me, Marcy, from time to time, we've talked about this TAC meeting jointly with the Children's Health TAC, particularly around overuse of psychiatric medications. And that's something that Dr. Lohr is an expert in and tracks that data out of a program out of U of L. But this hospitalization or inpatient services issue is one that, actually the Children's Health TAC and the BH TAC maybe could work on jointly. I don't know who's chairing that TAC right now. Do you happen to know, Leslie? Or Angie?
Which TAC did you say? I'm sorry.
Children's Health.
No, but I can find out.
It's
Yeah.
MHAG.
Do you have?
Oh,
okay.
is it? Okay. Matt Calvert from KYA.
There's
Yeah.
also a lot of work going on at the SEAC. There's a systems array subcommittee. I co-chair that with the chair of SEAC right now. And so there's a group and we're looking at some options for utilizing an out-of-state consultant around developing a children's plan of care. And so there's multiple. What we've learned is there's about 5 or 6 groups working on the difficult to place, challenging children, and the SEAC is trying to coordinate all of those activities, Sheila. So
okay.
wanting to, what we're finding is there's a lot of duplication going on right now, and we're trying to pull it together through SEAC.
Okay, well, maybe I should hook up with SEAC. May do that through you, Alan, with with that group out of Louisville. That's Gail Williams.
Yes,
it's the Pediatric Mental Health Behavioral Health Alliance, and they have been
very strong advocates.
Yeah, very strong advocates. So that's helpful. Thank you. The other piece of new business, and Diane's not on, and I guess Eddie Runnels was not able to join us today, but there is an upcoming public comment period for the ABI long-term care waiver, and that notice has gone out. So I will send that link out. I know some of us, we have strong representation on this TAC from the ABI folks. And so we really want to take a look at that long-term care waiver and make sure that it's offering all of the services that can possibly be offered to those folks. Many of them have also significant behavioral health issues, either before the brain injury or as a result of the brain injury. So we've always had a close working alliance with them. And I think we may want to pay attention to that 1915C public comment period. Any other new business from anyone who is attending the meeting? All right, just a reminder that the MAC meeting, and remember that's open to you all. I'll be sure that you get the link to it, but it's a great way to hear all of the latest. You hear directly from Commissioner Lee and from other staff at DMS, and then you also have a chance to hear from all of the TACs. And Mike, I just see this in the chat, so thank you. The PAR rally, annual rally for recovery, is September 17th from 11 to 3 at the U of L Student Activity Center. They are partnering with U of L, so we'll get that out to you all. And again, email me directly if you're not getting these notices and so forth, so that we can include you. And then our last BH TAC meeting of the year, remember this is earlier, this is the first week in November because the MAC meets a week earlier because of Thanksgiving. So it's November 3rd from 1 to 3, again via Zoom. And we will be setting our 2023 meeting calendar. So Erin, I'll check with you. We may need to change the date just to see what other dates may work out for DMS staff.
I'm currently working on the 2023 calendar for all the TACs, and I hope to have that out within a week or so.
Oh, okay. Yeah, because I think that we may need to move off of Thursday. I've had a number of people ask me to look for a different day because there are a lot of physicians and providers who are very, very interested and have not can't make these meetings. So I'll touch base with you directly, Erin.
Thank you.
Yeah,
and I'll start looking to see based off.
Yeah, because I know that we shopped around when we set this date because we were originally on a day that was just impossible for DMS staff. And Marcy, thank you for reminding me. The Kentucky Mental Health Coalition is celebrating its 40th birthday. Some of my gray hair is from holding together these coalitions over a long, long period of time. So we are having an actual in-person gathering. We're going to recognize some, we have a couple of retiring legislators like Tom Birch and Mary Lou Marzi and Joni Jenkins, who have done tremendous work on mental health and substance use disorders, who are leaving us, and we want to recognize them. We're also going to try to gather current and former commissioners and important people from the Department for Behavioral Health, formerly the Department for Mental Health, from the cabinet, and celebrate our birthday. So we're having lunch at the Capitol Plaza Hotel on September 28th. And Marcy has put the RSVP in the chat. It's actually a free event, but we need to have your RSVP so we know how many lunches to order. So we're hoping to have a celebratory crowd. We've not had anything in person and, like most groups, for 2+ years at this point. So we are eager to get together. And a little plug that you can renew your KMHC membership when you're on the website. So I'm dismissing the meeting or ending the meeting by acclamation. You get 5 minutes more out of your day.
Sheila, just one thing, I did send you the missing information, missing member and canceled appointments from Justin. I emailed that to you. It's quite lengthy, so you might want to take a look at it, and then you can have it for the next meeting.
Yeah, thank you so much. And we will have him on maybe to discuss it, but we'll also take a look at it. I'll share it with the voting members of the PAC to look it over. So thank you so much. And thanks to all of our DMS staff and helpers, and to the MCOs who are on. Thank you to our presenters. Really helpful to have KHA folks and the core folks. And thank you, Erin, as always, for your great support for us. So have a good day, and we will talk to you all, if not before, on November 3rd. Thank you,
everyone. Have a great day.
All right, thank you.
You too.